Hey everyone, welcome back to another episode of Physiology 2, especially for you. As you can see, in this video we will put the final pieces of the puzzle together. The Physiology 2 puzzle will be completed after this video, so again, especially for you, just a few more items that we've covered before to recap and then combined with a few last pieces of the puzzle so that the AVO2 difference and the distribution of blood flow will be fully clear, and you can map them all together into the concept of exercise physiology. And for you as a physiotherapist, exercise physiology is always going to be needed in at least the back of your mind if it's not the primary goal for your patients. But for most patients, exercise is always one of the modalities. So full understanding of exercise physiology is therefore key. This Physiology 2 course will complete with just the introduction into exercise physiology, whereas the next physiology courses will really dive into the further details of what exercise physiology really is. So stay tuned for the introduction and get excited for the next one. So we will look at the application into exercise. So all these concepts will be merged into examples of exercise. But again, as a reminder, the Fick equation is one of the most important equations in exercise physiology. So to repeat, the VO2 can be calculated by multiplying heart rate and stroke volume and the arterial venous O2 difference. If you merge heart rate and stroke volume together, you get this shorter version where VO2 equals cardiac output times the AVO2 difference. So if you look at the AVO2 difference, then you can see in the comparison between rest and exercise, the difference in the venous content and not really in the arterial content. So if you increase cardiac output, so if you compare submaximal biking at 150 watts to rest, the amount of O2 that's being delivered into the arteries, into the skeletal muscles, is not going to be different if you compare that per liter of blood. In this case, it's always expressed per 100 milliliters of blood. It's always this roughly of 20 milliliters per deciliter of blood. But then if you look at what in the mixed venous content is left, then you see that at rest, there's still 15 milliliters of O2 left per deciliter of blood. So the AVO2 difference is only roughly 5. So in exercise situations, especially during maximal exercise, you will see that a lot more of the O2 is actually being extracted, is being utilized by the aerobic process that happens inside the skeletal muscle cells mainly. And that's why the venous content is actually as low as 5. It will never be 0 because it's mixed venous content. So the blood distribution always is in such a way that, yes, most of the blood will flow to the active tissues where most of the O2 will be extracted, but it's always mixed with blood that has passed other tissues that are not so active and have therefore not extracted all the O2. So you will never find values of 0 in mixed venous content, although the values are definitely a lot lower than during rest. If you look at this graph, you can see on the vertical axis, the O2 content, again expressed in milliliter per deciliter of blood for the arterial content and the mixed venous content. So again, mind you, the word mixed is all about mixed blood that is from skeletal muscles, but also from other tissues in the veins. And then here you can see the oxygen uptake, which is again just a measure of exercise intensity, where you expect at rest that the arterial content is roughly this 20 or a little bit lower. And then here you can see this difference at rest is the AVO2 difference. If you compare the resting values then with medium intense or high intense exercise, you can see that the input is roughly the same, but the AVO2 difference increases because there's less O2 in the veins left after a full cycle. So what are the factors that are influencing this AVO2 difference? Well, first of all, and most of all, it's the redistribution of blood flow. So blood is redistributed to active tissues, and that will allow the active tissues to make better use of all the O2 that's being delivered. The inactive tissues are at least short down in terms of the blood volume that they deliver, so that more is available for the active tissues. Also, the capillary density is something that over time at least can change. So a training effect is an increased capillary density, which will allow even better extraction of O2 from the blood that is passing those capillaries by skeletal muscles. And that is due to the number of mitochondria mainly, and the efficiency of all the enzymes that are related to those mitochondria. And finally, the vascular improvements related to the capillary density will make sure that just the whole system will get more efficient. And more efficient means that from every drop of blood that is passing through, a lot more O2 is extracted post-training compared to pre-training. So the body is actually trained to extract and utilize the O2 that is passing more efficiently. Well, how about people with a heart disease? Well, what you can expect from heart failure, for example, is that they have issues with cardiac output that are usually caused by issues with stroke volume. And if there's really an underlying pathology, for example, with heart failure, then you could sometimes expect no real improvements due to aerobic training, as you would expect for a normal person. For a normal person, stroke volume is expected to increase after 12 weeks or 20 weeks of training aerobically. But for some cardiac patients, that is not realistic. What you could do instead is then focus on this AVO2 difference. So the Fick equation can still deliver a higher value for VO2, not because cardiac output is increased, but for example, because of the AVO2 difference that's increased. And this AVO2 difference can be triggered and trained, for example, by local muscle training. So what you see in some of the cardiac rehab programs is that they at least include a exercise modality or a package of exercises that are related to local muscle training. So with low resistance and high repetitions, you could still stimulate local aerobic improvements that will then cause the utilization of O2 locally to increase. So potentially you can increase the AVO2 difference, and with a constant yet restricted cardiac output, you could still upgrade the VO2 at least slightly. In these graphs, or in these two images, you can see the difference between rest and exercise. And here in a nice visual way, you can see that definitely during exercise, most of the blood flow is redirected to active muscle tissue, especially if you look at the percentages, then those percentages are a lot higher during exercise compared to rest, obviously. For other organs, for example, the heart, for example, the brain, you can see that those values also change. For some of these organs, the percentage changes. For some organs, only the absolute values will change. So what you can see here is that, for example, for the brain, a little bit more milliliters even during exercise are required for the brain, mainly due to a higher level of alertness, and more decisions have to be made because you're really in a fight or flight response, for example. But expressed as a percentage, of course, compared to the total, the brain will receive a lot lower percentage than at rest. If you look at the liver or the kidneys, they will actually have also in milliliters a lot less of blood flow if you compare exercise values to rest. And that is all to the fact that the body needs to make the right choices. So if you need a lot of energy in your skeletal muscles, you would like to have a lot of blood flow, a lot of the cardiac output actually reaching those skeletal muscles, and not have those have that blood flow through inactive tissues. So the body is able to constrict the arteries that are, or the arterioles that are leading to, for example, your intestines a little bit more compared to rest, whereas dilation is occurring in your active skeletal muscles, and that's a way for the body to make sure that this is regulated. Well, compared to the steady state graph that I showed you earlier, as you can see again here, a steady state response would be a normal increase, and then for any steady state exercise within steady intensity, for example, biking at 150 watts, you would expect the heart rate to remain steady. But sometimes in very extreme conditions, for example, if there's very hot conditions and someone is sweating a lot, or for other reasons losing blood volume, then what you could expect is what we call a cardiovascular drift. So in contrast to the steady heart rate, you could see a small increase in heart rate, not because of an increase in intensity, but because of a reduction in blood volume that is then leading to a reduction in stroke volume. And if you want to keep the same cardiac output, a reduction in stroke volume could be compensated by a slight increase in heart rate. So in very extreme conditions, this could be a good way for you to detect that stroke volume is actually dropping during exercise if you see that regardless of the exercise being steady, there's still a slight increase in heart rate. The cardiovascular drift. So it's an exception to the rule, whereas the rule is still that if the submaximal exercise intensity does not change, you would also expect the heart rate to not change for that steady state duration. In this graph, you can see graphically an extreme example of this situation where you lose blood volume. So in green, you see that there's a small reduction in blood volume, and that is then compensated, for example, by an increase in heart rate to compensate for the reduction in stroke volume. And also here you can see that the mean arterial pressure as a consequence is slightly dropping. And the overall idea is to always keep, at least for steady aerobic exercise, the cardiac output relatively constant. So in blue, you see the cardiac output. So regardless of the reduction in stroke volume, you see that due to the increase in heart rate, cardiac output can be kept relatively constant. Well, if you remember one of the previous videos where we looked at the oxygen need of the heart through the capillary arteries, the heart needs its own blood supply. And in cardiac physiology, you often can use the rate pressure product, RPP in short, to calculate the required O2 for the heart itself. And then what you see is that the heart rate times the systolic blood pressure is the representation of the rate pressure product. And the rate pressure product then represents the O2 content requirement of the heart. So if the heart rate goes up, the amount of O2 that the heart needs goes up. If the systolic blood pressure goes up, you can see the same. And what is interesting from this equation to note is that stroke volume is not part of the equation. So it's more efficient for the heart to actually deliver a certain cardiac output with a lower heart rate and therefore a higher stroke volume than the other way around. So for cardiac patients, for implications with cardiac rehab, this is definitely an important equation, although the number is not too important, but an increase in rate pressure product would represent an increase in the O2 requirement of the heart. And especially in angina patients, for example, or myocardial infarction patients, you see that this is often used to get an idea about the chance of having, for example, chest pain. If you look at blood pressure, then you see that the normal response of the blood pressure to exercise is that the systolic pressure would show a linear increase with increase in intensity, whereas the diastolic blood pressure will remain relatively steady or even show a slight decline. So the pulse pressure and the mean arterial pressure will both also increase, but it is mainly attributed only due to the increase in the systolic pressure that you would expect at higher intensities compared to lower intensities or compared to rest. And what is interesting for many patient applications is that there's definitely a difference in the response of lower body versus upper body exercise. So what you see here is that the O2 consumption for the same power output, so the same workload, is higher for activities that are done with the upper body compared to activities that are done with the lower body. So again, it's about the same workload that you deliver, let's say with hand biking or leg biking, but then the VO2 values for arm biking are higher than for leg biking. And in this graph, you can see for blood pressure, also an interesting difference. connected to the previous graph, where you see again exercise intensity expressed on the horizontal axis from low to high, and here the blood pressure for the systolic blood pressure and the diastolic blood pressure. So in red, you see diastolic pressure here, systolic pressure there for arm exercise, and in green you can see the leg exercise values for again systolic and diastolic. And what is interesting to note here is that for both diastolic and systolic values, arm exercise will cause a significantly higher blood pressure, both diastolic and systolic, compared to leg exercise. So for cardiac patients, for patients with hypertension, this is a very important difference to keep in mind when deciding to choose for a certain type of exercise. And this is again connected to the exact same intensity. So at any given intensity, leg exercise will lead to a lower blood pressure than arm exercise. And here you can see a few other standard values taken from one of the books. In resting position, but sitting or standing, what would you expect for normal resting heart rate values? What would you expect for stroke volume values? And what would you expect for cardiac output? Knowing your numbers is very important. So for any normal activity, maximum exercise or maybe slightly lower, expect a certain value that could be different if you compare different activities, even though the workload overall might be the same. And then here you see that if stroke volume and heart rate are slightly different, that could lead obviously to a slightly different cardiac output. So these are just imaginary average normal values to show you the difference in different activities for any given intensity, but also the difference in body position if you compare rest supine to rest standing, as we saw earlier. So how is this whole blood flow and blood distribution regulated? Again, we have to look at plain physics. So it's determined by cardiac output, but the body is able to regulate, especially through the arterioles, and that's where plain physics again really come in handy. Here you see that the flow rate is 10 milliliters per minute, and here the flow rate is also 10 milliliters per minute. And that is due to the fact that the pressure difference between the start and the end of this tube is exactly the same, and that determines, in this example, the amount of flow. So it doesn't matter how high both values are from the beginning to the end, as long as the pressure difference is the same, blood flow will also be the same. But how the body regulates this is by changing the diameter of the tubes that the blood is flowing through. So the diameter is something that will have an effect on the resistance. The length of the tube will have an effect on the resistance, and the viscosity of the fluid, water or blood, depending on what you look at, will have an effect on resistance. So what you can see right here is that you put a certain amount of volume in here. If the diameter over here is higher, then according to these formulas, there will be a lot more blood flow into this direction than compared to a diameter that is a lot smaller. So the length of the tube in this case is not changed. The viscosity of the fluid is not changed. It's simply regulating flow by regulating the diameter of the tube. And this is where in the human body you see how general physics compared to human body values. The flow through a system of tubes is depending on the pressure difference divided by the resistance. So if you can reduce the resistance, the flow will go up, or if you can increase the pressure difference, the flow will go up as well. As the pressure difference between arterial and venous components of the whole cardiovascular system is basically just the mean arterial pressure, you can see that the flow through an organ is actually the mean arterial pressure divided by the resistance through those organs. And that is just because the venous pressure is close to zero, so that means that the mean arterial pressure minus zero is the pressure difference. So what the body can do is just try to regulate mean arterial pressure and or the resistance. And usually this is done, except for some strength training examples, for instance, the resistance is something that the body will regulate by manipulating the different diameters. And that's what you see here in this drawing where you see these arterioles that are leading from the bigger arteries towards the active skeletal muscle tissues, for example. These smooth muscle tissues surrounding arterioles can either constrict to reduce the diameter, or they can relax by lowering their activity, and then they will increase the diameter. So if the diameter is increased due to smooth muscle activity reduction, the resistance will go down and the flow could go up. And that is regulated by a lot of different factors. So you have local control factors, chemicals that are released, for example, inside the cells or close to the cells that would trigger either vasodilation or vasoconstriction. But there could also be hormonal factors, especially epinephrine that is circulating into the bloodstream, or there could be neural input that will also trigger vasodilation in certain areas and vasoconstriction in other areas. So based on this graph, you should be able to imagine what for a skeletal muscle tissue would be triggering factors for dilation in exercise, and in other organs what those factors would cause in terms of constriction. And that is how the body can regulate more blood flow to certain areas and less blood flow to other areas. So the driving force of the whole cardiovascular system is the heart, and that will cause the mean arterial pressure to always be sufficient to supply all the different areas with blood. So the body is trying to regulate the cardiac output and the total peripheral resistance to try and keep this mean arterial pressure relatively constant for an optimal blood flow and perfect homeostasis. And finally, all of this is graphically visualized in this chart. So what you can see right here is that the mean arterial pressure on this side is the product of cardiac output and total peripheral resistance. And here on this side, you can see all the different factors that are somehow affecting the total peripheral resistance. Whereas over here, you can see all the different factors that we've covered earlier and how they actually affect the cardiac output. And then mean arterial pressure is again affected by all these factors. If cardiac output goes up or goes down, or total peripheral resistance goes up or down, the mean arterial pressure will change. So what are the training effects compared to exercise? We saw a lot of short-term instant effects of exercise, but what are the proven training effects of a solid 20 or 30 week training program for aerobic improvements? What are they? Well, first of all, we have heart rate, we have stroke volume, cardiac output, and VO2. All factors that are part of the FIC equation. So my challenge to you is to give me a list and to give yourself a list of all the different training effects. Does cardiac output go up after training, or does it go down? Does heart rate go up for any given exercise, or does it go down? And finally, also for AVO2 difference and blood pressure, you should be able to list the training effects of all these factors due to aerobic training. Good luck. Well, for heart rate, here you can see for heart rate on the vertical axis, for the time on the horizontal axis, you can see that pre-training, the heart rate will rise, and then for any steady exercise value, you would expect the pre-training values to be higher than the post-training values. And that is simply due to a increased stroke volume that you would expect after 10 or 20 or 30 weeks of training. And as a consequence, heart rate for that particular same intensity will go down because cardiac output in the end is expected to be relatively steady. The recovery is also an interesting factor where you see that a training effect is also that the recovery is expected to be faster post-training compared to pre-training. Blood volume is expected to increase post-training compared to pre-training. So the number of red blood cells will increase in absolute number, but the increase in plasma volume will outweigh the increase in red blood cell count. And that's the reason why the hematocrit value is actually reduced if you compare post-training to pre-training. So this is one of those variables that they measure also with doping agencies in trying to catch people that try to manipulate their hematocrit value artificially. And one of the reasoning behind any artificial enhancement that they would try to conclude is because it will be expected to be the opposite if someone would do regular endurance training. So regular endurance training would cause a reduction in hematocrit value and not an increase in hematocrit value. And here you can see a lot of these different factors again in relation to VO2 max, where you see here the Fick equation visualized with cardiac output on this side and a VO2 difference on the other side. So all these factors try to influence either the AVO2 difference or the cardiac output, and then the product of those two, the VO2 max, will be affected accordingly. So have a good look at this graph to see again if you can understand what all these different factors do and how they influence finally the VO2 max, one of the most essential physiological parameters in exercise physiology. All right, that was it for this video. I hope you liked it. Please let me know if you have any questions, and to celebrate again that you completed another great video, here is some confetti. Hope to see you in the next one.